Hi everybody, welcome to Critical Care Sunday webinars. And today is webinar number 157, and we have a very important topic today, carbapenems. And to walk us through this topic would be Dr. Neha Gupta. She's taken many wonderful lectures for us previously also, and some of you may have seen them. They're up there on our YouTube channel. So just to introduce her to you, she is a senior ID physician and a senior consultant at Fortis Memorial Hospital, Gurgaon. She's also the FNB ID from the first batch of India, and she's the founder of NG Swasth. She's also the joint secretary for SITSCON for the coming year. So with that, we hand it over to Dr. Neha Gupta.
Yeah, thank you so much, Dr. Tapesh. I'm the joint secretary of SIDS currently, and SIDSCon, we are going to have it in August this year. So welcome you all for the SIDSCon. Thank you, Dr. Tapesh, for providing me this opportunity again. And I'm going to begin my presentation on carbapenems. So I'm Dr. Neha Gupta, infectious diseases specialist, and currently I'm attached with Fortis Memorial Research Institute, and I'm founder of NG Swasth, our initiative for creating awareness regarding infectious diseases and their early diagnosis. So today we are going to delve into the world of carbapenems, which are a vital tool in the armamentarium against infectious diseases. And I'm going to briefly this is going to be the outline of my talk today. We're going to cover the carbapenems, a brief overview of these important antibiotics, their mechanism of action and resistance, basic drug susceptibility interpretation of the culture report, and the CLSI breakpoints related to the carbapenems, the PK/PD of the carbapenems, and what is different in critically ill patients, what are the various treatment options, or how do we use carbapenems empirically as well as in the treatment of resistant gram-negative infections. What are the trials? Especially, we're going to briefly discuss the merino trial, few case scenarios, and the impact of judicious use of carbapenems on the antimicrobial stewardship and the patient outcomes. So to begin, carbapenems are the derivatives of thenamycin, an antibiotic which is produced by soil organism Streptomyces cattleya. Now, the carbapenems which have been approved in the USA include ertapenem, meropenem, imipenem, and the doripenem. Additionally, in Japan, panipenem, biapenem, and tebipenem are also approved. At the moment in India, the carbapenems which are available to us are the ertapenem, meropenem, imipenem, doripenem, as well as the biapenem. Now, carbapenems have a core structure. How does it differ from the penicillin? So the carbon replaces the sulfur at the C2, and there is a double bond between the C2 and C3. This particular change from penicillin is responsible for the various properties of the carbapenems. And all of the other carbapenems like the ertapenem, mero, dori, as well as the imipenem have a different side chain, which is responsible for variation in their properties. For example, imipenem, it gets degraded by the mammalian renal dihydropeptidase, and it has to be administered with an anti-DH1 antagonist, which is the cilastatin. Because of the changes in the structure of the erta, mero, and the doripenem, they are they're very stable and do not need a DH1 antagonist to be administered along with them. How do the carbapenems act? So carbapenems inhibit the cell wall synthesis. And for us, it's important to understand the different configurations of the gram-positive and the gram-negative bacteria. The cell wall is different The cell wall is thick in case of the gram-positive because of the presence of the thick peptidoglycan layer, and few of the gram-positives may have a capsule. This is followed by a thin cytoplasmic membrane and, of course, the cytoplasm. Then there are these penicillin binding proteins which are present and are important for the synthesis of the peptidoglycan layer. Now, this peptidoglycan layer, which is very thick in the gram-positives, is thin in the gram-negative bacteria. And the gram-negative bacteria, they have an outer membrane, which is the outer lipoprotein polysaccharide phospholipid membrane, and the inner cytoplasmic membrane. And there are these periplasmic spaces, which are home to the beta-lactamases, which hydrolyze the various beta-lactams. So how do the carbapenems act? They inhibit the cell wall synthesis. And and how is it different from the other beta-lactams? That the carbapenems, they are able to penetrate through the outer lipopolysaccharide membrane better. They have stability against certain beta-lactamases which are found in the periplasmic space, like the ESBLs and the AMCBLs, and they have very high affinity against certain multiple penicillin binding proteins. So they can bind to penicillin binding proteins 1A, 1B, 2, and 4, and they have lesser propensity to bind to the penicillin binding protein 3, which is usually the target for the aminopenicillins and the cephalosporins. So remember that we usually have penicillin binding 4, and usually it is the 1A, 1B, 2, and 4, whereas to the lesser extent, it is the PBP3 to which they bind. And since they bind to the multiple penicillin binding proteins of the various bacteria, they have a broader spectrum of activity. How do carbapenems acquire resistance? So the carbapenem resistance develops either as a result of a single mechanism or because of a combination of the various mechanisms which can occur in a gram-negative bacteria. So the most common mechanism which results in hydrolysis of the carbapenems are the presence of beta-lactamases which are present in the periplasmic space. And these beta-lactamases hydrolyze the carbapenems are known as the carbapenemases. Sometimes there can be additional mechanism of resistance. For example, there can be overexpression of the transmembrane efflux pump, which confers resistance to the meropenem. And in case of Pseudomonas aeruginosa, there can be this loss of porin channels or downregulation of the outer membrane protein, OPRD, with the background of the AMC beta-lactamases will result in more resistance to the imipenem as compared to the mero or the doripenem. There are other outer membrane protein downregulations like the OMPRK, which is responsible for resistance in Klebsiella pneumoniae, and outer membrane protein CF, which is responsible for resistance in case of Enterobacter. For E. coli, resistance develops because of alteration in the PPP3, which is becoming the most common mechanism of resistance or carbapenem-resistant E. coli in India. The carbapenemases, which hydrolyze the carbapenems, can be classified into two major groups, which includes the metallobeta-lactamases consisting of the NDM, VIM, and M, and the serine beta-lactamases consisting of the class A KPC, class C includes AMPC, and class D includes the oxacillinases. Out of these, the OXA48, OXA181 like cluster is found especially in the Klebsiella as well as the other Enterobacteriaceae, whereas the OXA23 is found in the Acinetobacter baumannii. There are certain metallobeta-lactamases which are intrinsically present in some non-fermenting GNB. So we have non-fermenting GNB, which is usually Pseudomonas as well as the Acinetobacter. But besides this, we have Stenotrophomonas and Elizabeth Kingi meningoceptica, which have intrinsic NDM beta-lactamase in their periplasmic space. And that is why they have intrinsic resistance to the carbapenems. So what is the where are these carbapenemases usually found? So the first one we always heard was, to begin with, it was the KPC, but it is usually seen in the USA and in our neighbor in China. In 2010, the first publication on NDM was from Dr. Kamala Rodriguez and Dr. Rajiv Soman sir in 2010. Subsequently, there has been also origin as well as the spread of other oxacillinases which have been described in India since 2006 and 7. The first was OXA 181, and now we are seeing OXA 48 in many parts of the India, which is close to 20 to 30% among the Klebsiella pneumoniae. Now let's go on to discuss the basic drug susceptibility interpretation and a few points regarding the breakpoints of the carbapenems. So this is a patient who's a 45-year-old gentleman with acute pyelonephritis with septic shock. There was urine as well as a blood culture which is growing the E. coli. Now this is from 2008, but it's a very good case for understanding the which is the likely mechanism of resistance. Hence, I'm presenting this. So here, what is with this particular susceptibility? What is the mechanism of resistance? So here we have the ceftriaxone and the ceftazidime, which is resistant. The BL-BLI combination, the piptaz and the cephalosporin sulbactam is susceptible. The imipenem, meropenem are susceptible as well. And we have cefepime, which is resistant. So this is very likely ESBL. What is an ESBL? An ESBL is which confers resistance to the extended spectrum beta lactamases, that is the third generation cephalosporin. So in the culture report, the third generation cephalosporins are going to be resistant, and there is also going to be resistance to the aztreonam as well as to the cefepime. But susceptibility to the BL-BLI combination of cephalosporin sulbactam or piperacillin tazobactam. Now, if suppose we have the carbapenems as resistant, then it is going to be the carbapenemases. A word about the inducible AMC. So there are certain organisms which are known as the spice organisms, which includes the Serratia, Pseudomonas, indole positive proteus, which includes the Proteus mirabilis, Citrobacter, as well as the Enterobacter cloacae, as well as the Klebsiella aerogenes. These are the spice organisms. They are AMCBL producers. What is the clinical implication? So if these bacteria are exposed to oxyminogrouppenicillins, that is, say, ceftriaxone or imipenem, then it induces the AMCBL production, resulting in resistance to the ceftriaxone as well as to the imipenem, but not to the cefepime or the meropenem. So here, if the culture report is showing resistance to cefepime, then it is likely ESBL. But if suppose we have the BL-BLI combination, which is intermediate, but we have cefepime, which is susceptible, then it could be AMCBL. Now, if there is a culture report where there is a bacteria, say Citrobacter, and it is susceptible to imipenem, or it is susceptible to ceftriaxone, but if these antibiotics are used for the Citrobacter, it will result in production or induction of the AMC beta lactamases, which will hydrolyze the ceftriaxone as well as the imipenem, and they will become resistant. So ideally for these bacteria, we should not be using the carbapenem, imipenem per se because of the possibility of inducing the AMC beta lactamases. How was the carbapenem resistance identified? So way back in 2010, and this is the first publication in the world, and we proudly say that it was from our own India, from the pioneers, Dr. Rodriguez, as well as Dr. Soman, and the group Dr. Ashit Hegde, sir. Initially, the carbapenemase or the carbapenem resistance was detected, in fact, it had to be detected through this modified Hodge test. And there were no real breakpoints which were established. And there was also a possibility of the VITEC or the automated systems missing out the carbapenem resistance. So in 2010, modified Hodge test was recommended. Subsequently, there has been evolution, and we have well-defined breakpoints for the carbapenem susceptibility as well as for the resistance. So for the ertapenem, the susceptibility breakpoint is less than 0.5, whereas for the imipenem, meropenem, and the doripenem, for the Enterobacteriaceae, excluding the Salmonella as well as the Shigella, the susceptibility breakpoint is 1 and the resistance breakpoint is 4. And for the Pseudomonas as well as for the Acinetobacter, the susceptibility breakpoint are different. The imipenem, mero, and the doripenem susceptibility breakpoint for Pseudomonas as well as for the Acinetobacter is 2. So the carbapenems have different susceptibility breakpoints for Enterobacteriaceae and for Pseudomonas and Acinetobacter. For Enterobacteriaceae, it is 1, and for Pseudo and Acinetobacter, it is 2. Now, we also have molecular assays which can detect the various carbapenems or the carbapenem resistance. We can detect it through the expert CARBA-R, the BCID panel which is available. We also have the CPO detect, and we have this NG CARBA-5 or the lateral flow immunoassay, which is an immunochromatographic detection. And all of them can detect the 5 major carbapenems which confer resistance to the carbapenems. Out of these, usually the most commonly performed is the expert CARBAR with a TAT of close to 15 minutes, whereas the lateral flow assay is usually identifies in 15 minutes from the positive culture that which the likely carbapenems. Coming to the PKPD as well as of the carbapenems, and how is it different in critically ill patients? So we all know that there are 3 major PKPD parameters which determine the efficacy of the antibiotics, and that is the time above MIC, the concentration of the drug above MIC, and the area under curve AUC by the MIC. For the beta-lactams, it is the time above MIC which determines their bactericidal activity, and it is usually considered that the free drug concentration should be 4 times above the MIC of the organism. For at least for the carbapenems, it is 30% of the dosing interval, and in critically ill patients, ideally it should be 100% of the dosing interval. So what is the clinical implication? That these drugs, that the beta-lactams, have to be given as more frequent dosing. The drugs which have got concentration-dependent kinetics, they have to be administered as a single daily dosing. And usually the drugs which have got AUC by MIC and have got long half-life, they have to be given as a loading dose followed by the maintenance doses. There is also a concept of mutant prevention concentration, and this is the concentration we would like the antibiotics to achieve so that the generation of antimicrobial resistance is avoided. This MPC is usually 4 times above the MIC. And ideally, anyways, for clinical success, the concentration of the drug should be 4 times above the MIC, and the concentration should have good or it should be a good concentration at the site of infection. So what happens in critically ill patients? How is the management different? This is it is different because in critically ill patients there is alteration in the pharmacokinetic and the pharmacodynamic, which complicates the dosing. And also for us to understand this, we need to understand the basic differences between the hydrophilic as well as the lipophilic antibiotics. So the hydrophilic antibiotics includes the beta-lactams, aminoglycosides, glycopeptides, and beta-lactams include the carbapenems. Usually, they have smaller volume of distribution and low protein binding and have low intracellular penetration and lesser penetration to the deep-seated infections and predominant renal clearance. Whereas the lipophilic antibiotics, which usually includes the tetracyclines, macrolides, they have a larger volume of distribution, and they have very high the tissue penetration is very good, predominant hepatic clearance. In critically ill patients, because of the changes in the volume of distribution as well as the augmented clearance, there is a possibility, or usually what happens is, because of the leaky capillaries, there is an increase in the volume of distribution, and patients who have got low albumin, there occurs alteration in the protein binding. So all this results in an augmented renal clearance. There is increased clearance of the hydrophilic antibiotics, resulting in suboptimal concentration. So there is a chance, or there is a possibility, that in critically ill patients, the carbapenems which are given may not achieve the adequate antibiotic concentration. This is more pronounced for drugs which have got a high protein binding. So ertapenem among the carbapenems is a very high protein bound drug with close to 90% protein binding. As a result, when there is a patient with very with sepsis or severe sepsis, there, because of these changes, the concentration of the drug is going to be even lower. And that is why, even though ertapenem is recommended for the intra-abdominal or for the UTI, but it should not be used for during the initial stages or during the phase of bacteremia. Later on, for de-escalation, we can use ertapenem. Coming to the levels or the antibiotic levels of the carbapenems as well as the beta-lactams in critically ill patients. So there is this famous study which was done by Jason Roberts, and it was a prospective multinational pharmacokinetic point prevalence study where the mid-dose and the trough beta-lactam concentrations were measured. And out of the 248 patients who were treated for the infection, 16% did not achieve 50% of the free drug concentration of time above MIC. And these patients were like 32% less likely to have a positive clinical outcome. So one dose does not fit all, and we have to tailor our antibiotic doses based on the severity of infection as well. Prolonged infusions of the beta-lactams has become a standard of care, but are prolonged infusions for all. And initially, because we want to achieve the level of the concentration of the antibiotic above the MIC, the first dose has to be a loading dose, and then subsequent doses of the antibiotic have to be given as prolonged infusions. This is a table which briefly summarizes the antibiotics with their doses. So ertapenem is usually recommended as 1 gram once daily because it is highly protein bound and has a longer T-half of 4 hours. Meropenem is usually recommended at 1 to 2 grams depending upon the severity as well as the site of infection. So in critically ill patients, a higher dose, as well as in patients where the site of infection is brain or bone, where the penetration of the beta-lactams is limited. So a higher dose is recommended. Imipenem is usually 500 milligrams, which is to be given 6 hourly, or it can be 1 gram IV 8 hourly. The infusion time is over 2 hours for the imipenem, and it is 3 hours for the meropenem. And the doripenem dosage is 500 milligrams to 1 gram 8 hourly. As they are renally cleared, so renal dose modification is also recommended. Coming to the where can we use the carbapenems and also discussion on the merino trial. So this is a table which briefly summarizes where we can use carbapenems as the empirical choice. So the choice of antibiotic will depend upon what is the site of infection and which are the likely organisms and their likely drug susceptibility. So for example, if a patient is presenting with a syndrome of meningitis, where the likely organism is strep pneumoniae, Neisseria meningitis, or rickettsiosis. So empirically, because it's gram-positive, here the drug of choice is going to be ceftriaxone with vancomycin for covering the resistant strep pneumoniae, and of course, maybe doxycycline for the rickettsiosis. So here, carbapenems in a community-acquired meningitis is not recommended. If the person is aspirated, then probably adding carbapenem may be justifiable to cover the resistant gram-negative from the into the lung. For a patient who is coming with pneumonia, it again will depend upon the severity of infection. For patients who have got prior severe pneumonia who are admitted in the ICU or have prior exposure to the BLBLI or to the carbapenems or with structural lung disease, carbapenem is justifiable. But otherwise, OPD basis or inpatient non-ICU, we can go ahead with the third generation cephalosporins or even amoxicillin clavulanic acid along with azithromycin. For intra-abdominal infections and for the urinary tract infections, as usually these may have ESBL producing organisms, the gram negatives, gram a choice between the BL-BLI combination or carbapenem can be considered based on the severity of illness, the source control possibility, as well as the immunocompetent or the immunocompromised status. So the choice or the empirical choice of the antibiotic or the carbapenems will depend upon several factors like site, organisms, susceptibility, immune status of the host, and the prior antibiotic exposure. Coming to an important trial, the merino trial, which was assessing the efficacy of piperacillin tazobactam versus meropenem on the 30-day mortality for patients with E. coli and Klebsiella pneumoniae bloodstream infection with ceftriaxone resistance. It was a randomized controlled trial which included close to 187 patients, and in the pip-tazo group, 23 patients had a mortality of at 30 days. So the mortality was 12.3% in the piperacillin tazobactam group as compared to 3.7% in the meropenem group. And the authors concluded that the piperacillin tazobactam did not result in the non-inferior, as compared to the meropenem, did not result in a non-inferior 30-day mortality. As a result, in fact, this particular trial was discontinued even earlier. So here, as we see, the 30-day mortality was higher in the piperacillin tazobactam group, and this 30-day mortality was much more pronounced in patients who did not have urinary tract infection. So in UTI, piperacillin tazobactam was comparable to the meropenem, but in the non-UTI syndromes, the meropenem was better as compared to the BLBLI piperacillin. Similarly, in immunocompromised patients, the meropenem group had a lesser mortality as compared to the piperacillin tazobactam group. A few case scenarios. This is a 65-year-old lady who had cholelithiasis and then underwent cholecystectomy, and then she developed the septic thrombophlebitis. This was the blood culture from the central line, which grew Klebsiella pneumoniae. And this was, here we see, this is meropenem resistance and imipenem intermediate. This was colistin susceptible at that point. Now it will be intermediate. So this patient was still febrile despite on being ceftriaxone EDTA sulbactam along with colistin. So what do we do in this patient? Can we extrapolate this intermediate susceptibility of imipenem? So we requested for the MICs, and the MIC value turned out to be 2, whereas the meropenem MIC was 16. So we have to compare it with the susceptibility breakpoint, and the imipenem susceptibility breakpoint is 1. So this is just above the susceptibility breakpoint, and we all must have observed discordant results of imipenem and meropenem. This is because in addition to the beta-lactamases, there are other mechanisms of resistance. So probably in this particular patient, the efflux mechanisms are more active, which are resulting in more resistance to the meropenem as compared to the imipenem. So here we discontinued CEA, and along with colistin, imipenem was added in the higher doses, and the patient's fever resolved, as well as there was clearance of the bacteremia. So another important question is, should we use carbapenems as monotherapy or should we use it as combination therapy? So if carbapenems are being used for the ESBLs or for the MCBLs, they can be used as monotherapy. There is no need for combination therapy. However, if suppose the carbapenems are being used for carbapenem resistant enterobacteriaceae, in that case, in patients who have got a low mortality score, then monotherapy is fine, but probably a combination therapy is better if there is a high mortality score. So again, we have to decide, that is maybe with polymyxins and carbapenems. If there is no other alternative to carbapenems, then we can use then carbapenem can be used with polymyxins for the very sick patients. And I would like to mention about the study from DICOS, that till what MIC can we use the carbapenems. So this was an earlier study which showed that probably when the MIC is 32, and if we are using the carbapenems, which is like meropenem infusion of 2 grams as prolonged infusion over 8 hours, it can still achieve the 50% time above MIC in few of the patients, and probably around the MIC up till the MIC of 16 can be achieved in close to 30% of the patients. But that is why at that point we were using, before the availability of ceftazidime, avibactam, or even fosfomycin, a combination of polymyxins with high dose carbapenems. But now we have more data that the carbapenems can be used only if the MIC value is between 4 to 8. And in our country, we usually have a MIC of the carbapenem resistant gram negatives more than 16, or maybe reported from the Vitek is more than 16, but it is probably 124 or even higher. So with such high MIC, using carbapenems for such resistant CRGNBs is not advisable. So susceptible antibiotics, for example, it can be other, it can be polymyxin or it can be fosfomycin if E. coli is susceptible, Klebsiella pneumoniae, ceftazidime, avibactam, or a combination of ceftazidime, avibactam with aztreonam, or in certain cases, maybe using cefepime, zidibactam as well. And tigecycline for the intra-abdominal infections, if susceptible, can be used. Let's look at this patient. This is a elderly lady who had worsening dyspnea, cough, fever, hypoxia, and a new left upper zone infiltrate. This was admitted. So this is pneumonia who was admitted in the ICU. And so for this patient, which of the following antibiotics is most appropriate empirically? So all of us probably will go for meropenem with azithromycin. Here, this patient had the streptococcus pneumoniae isolated from the blood, which is susceptible. So the meropenem was de-escalated and this patient was initiated on amoxicillin clavulanic acid and azithromycin was continued. So this is how we have to modify or assess every day on clinical rounds that whatever we have started, even if the patient is improving based on the clinical response as well as the culture and DST, that should we continue carbapenems, or is there is a possibility of discontinuing or de-escalating down to a lower spectrum or to a narrow spectrum beta-lactam. Now, this patient had only pneumonia. What if the patient had community-acquired meningitis? So it's important to remember that patients who have got, if a patient has got pneumonia and has got bacteremia, then it's important to know whether the patient also has got meningitis or not, because the susceptibility breakpoints are different for the meningitis as well as for the non-meningeal strains of the Streptococcus pneumoniae. For meningitis, the susceptibility breakpoints for the penicillin as well as for the ceftriaxone are lower. This is because the penetration of the beta-lactams into the brain is limited, and that is why the CNS breakpoints are different from the non-meningeal breakpoints. So here, then subsequently, if suppose there is resistance, so we start off with, if suppose this is a community-acquired meningitis, the empirical choice of the drugs for empirical choice should be ideally ceftriaxone with vancomycin with ampicillin to cover the Listeria monocytogenes also. And if suppose the patient has got aspiration, then probably giving meropenem and vancomycin is justified, but otherwise ceftriaxone, vancomycin and ampicillin. Coming to the urinary tract infections, and here, if it is a severe infection, then carbapenems are justified. For non-severe infection, non-bacteremic UTI, then BL-BLI combination can be used. Let's look at the impact on the antimicrobial stewardship of judicious use of the carbapenems. Now, this is a 22-year-old gentleman who had undergone an allergenic bone marrow transplant. Then 5 years later, he presented with fever and diarrhea for 5 days. His counts were normal. There was a slight decrease in the platelet count, and there was an increase in the LFT. The Vidal was positive, and this patient had a Salmonella typhi from the positive culture. Now, somehow I think the report was missed, and this patient had been on ZNM, Targocid, Xylestin, and many other drugs, including the carbapenem. So for this patient, I think again the interpretation of the culture report is important, and this patient was subsequently treated only with azithromycin for close to 10 days. It's important to remember that there are certain gaps in the spectrum of the antibiotics, including the imipenem, including the carbapenems, and the ertapenem. They do not have activity against the Pseudomonas acinetobacter, and the carbapenems, they do not cover MSSA, MRSA, enterococci, which is only been enterococci are also not covered. So meropenem does not cover enterococci. Imipenem has activity against the Enterococcus faecalis, but not against the Enterococcus faecium. I would like to mention about our poster, which was related to de-escalation and change of antibiotics in patients with infective endocarditis after the ID consultation, which we had presented as a poster in SITSCON in 2015. ID, a friend in need for infective endocarditis. And following the ID consultation, a change in the antibiotics was performed in 25 out of the 32 patients over a period of close to 2 years. And of these, the de-escalation was performed from meropenem as well as a BL-BLI combination to the narrow spectrum ampicillin, ampicillin, and the third generation cephalosporins. So this is how we have to know the syndrome and then choose our antibiotics accordingly. This is another case which it's important to remember that suppose if you have a patient who is on a BL-BLI combination and then has become septic, then the next possible organism is going to be a carbapenem resistant bug. So if the patient is on cephalosporin sulbactam or piperacillin tazobactam and then deteriorates, then it's going to be a CRA. So escalation from BL-BLI to meropenem is not really justifiable. It has to be a one level up. So it has to be either a polymyxin or the ceftazidime avibactam based combination therapy. Here, this is a table which briefly summarizes the various the beta-lactamases as well as the antibiotics which can work against these beta-lactamases. So the ceftriaxone is hydrolyzed by the ESBL and the AMCBLs, and meropenem act against the ESBLs as well as the AMCBLs. We also have combination of drugs like the meropenem vaborbactam and imipenem relibactam, which is available in the US, and they are able to resist the hydrolysis from the KPCs. And of course, if it is NDM, OXA48, then it will result in hydrolysis of the meropenem. So a suggested workflow probably would be when there is a culture positive with a GNB, and we need to then find out immediately, like, okay, here. Yeah. So if there is a blood culture which is positive for the gram-negative bacteria, or even any other specimen, say a urine culture, so we need to find out whether it's an Enterobacteriaceae or it is a NF-GNP or a non-Enterobacteriaceae, which can be done either by a gram stain or with a multidrop. And then on the positive, on the on the GNP, we can perform an expert carbapenem that can help in detecting the carbapenems. If it detects a carbapenem, then it is a carbapenem resistant pathogen. However, if suppose it is not detecting the carbapenem, then there is a possibility of a ESBL, amphibian, and de-escalation of the antibiotic can be done. So if suppose the patient is on polymyxin, then with careful analysis, de-escalation can be performed. This is a table which illustrates the comparison between the 4 commonly used carbapenems in our country, erta, mero, and doripenem. So as I mentioned that besides there are differences in the structure, and I have mentioned regarding the DHP1 for the imipenem, which requires co-administration with the cilastatin. There is some basic differences in the resistant mechanisms. Efflux pumps are more active for meropenem resistance, whereas downregulation of the OPRD along with the background of amphibian confers resistance to imipenem in case of Pseudomonas aeruginosa, and alteration in the penicillin binding protein 3 in E. coli confers resistance to the carbapenems. The T-half of ertapenem is 4 hours, whereas for mero, and doripenem, the T-half is 1. Ertapenem is very highly protein bound, whereas the imipenem is lesser, it's 20%. Mero and doripenem have very less protein binding. So the clinical implication is that in patients with severe sepsis or in critically ill patients with augmented renal clearance, the chances of ertapenem suboptimal concentration is more. Hence, it should not be used during the acute phase. Later on can be used for the de-escalation. And because of the high protein binding and and a long T-half, it is once daily administration. Advantages, ertapenem can be given both as IV or as intramuscular, whereas mero, and dori, they have to be given as more frequent dosing. For imipenem, preferably 6 hourly over 2 hours infusion. Mero is 8 hourly over 3 hours, and dori is again 8 hourly infusion. All of them have renal elimination. So in patients with decreased creatinine clearance, doses have to be modified. Adverse drug reactions have been noticed with the carbapenems. Seizure potential is more. It's 1 to 2% with the imipenem, whereas it's 0.1 to 0.3% with the meropenem. There is interaction of ganciclovir. Ganciclovir and imipenem should not be given together. It also increases the seizure potential. And similarly, valproic acid and imipenem again has got seizure potential. The spectrum of activity of the carbapenems, they have activity against the gram-negatives, the ESBLs, amphibians, activity against the gram-positive cocci as well, but these gram-positive cocci are Streptococcus pneumoniae or the beta-hemolytic streptococci. They are not the drug of choices for the MSSA or MRSA, and even they have no activity against the enterococcus. Imipenem has activity against the Enterococcus faecalis because it can bind to the PPP3. And of course, ertapenem is mainly indicated for the UTI and intra-abdominal infections, not for bacteremia, whereas imipenem, mero, and doripenem can be used for all sites. So I think I will summarize it saying that it's very important for us to just to use the antibiotics judiciously, and especially the carbapenems, which have become the most common antibiotics to be used empirically at times. And we have to always reassess ourselves on a daily basis that can we de-escalate down from carbapenem or not. Thank you so much.
Thanks, Dr. Neha, for a wonderful lecture as usual. So please stop the share screen. So if there are any questions, please put them up. We'll answer the questions. Meanwhile, I'll just add a couple of points to what she has said. So first of all, a lot of people ask about biopenem, why we are not using biopenem. So I think the problem with biopenem is that the MICs are not known clearly, so that becomes a problem with the use of biopenem. So it's a new molecule. And the other thing is about doripenem. So, doripenem has a great advantage in the fact that its seizure potential is actually practically nil. So in situations where, there's a risk of throwing a seizure, one has to use a carbapenem, one might consider using doripenem, which I think is underused. And then thirdly, about ertapenem. So if you get ertapenem resistance anywhere in your culture sensitivity, that practically means that the bug is resistant to all carbapenems. So, ertapenem resistance means there's a pan resistance to all carbapenems. And fourth, please, in septic shock and in profound sepsis, use the carbapenems in highest doses. Nobody dies of high doses, but people die of inadequate dosing all the time. So please remember, use highest doses as possible in patients with septic shock. So anything else you want to add, Dr. Neha?
No, I have, I think,
Okay,
described everything. Yeah.
So I think there are no
If there is any particular question, then we can answer. Otherwise, I think.
So there are no questions right now. There might be questions in a chat box later on. I'll just answer them and post them to you if I can't answer them. So I think with that, we'll end the session. Dr. Neha, thank you so much. Take care. Goodbye.
Yeah, goodbye.
Thank the audience for their patient listening. Thank you so much.